Hello everyone. In the last video we have talked about the cardiac output and one of the determinants of cardiac output, that is heart rate. In this session we'll learn about the stroke volume. Stroke volume, which refers to the ejection of the blood by each ventricle per systole. So it is dependent on three factors. One is preload, referring to venous return, myocardial contractility, and then afterload, which refers to peripheral resistance. Preload. Preload, also known as intrinsic or heterometric regulation of stroke volume. Intrinsic because it is intrinsic to cardiovascular system, and heterometric means there is a change in length of the ventricular muscle fiber before its contraction. So preload is the degree to which myocardium is stretched before it contracts. In the heart, extent of preload is proportional to end diastolic volume. Means increase in end diastolic volume increases preload. Now this can be explained by the Frank-Starling law, which states that within physiological limit, force of contraction of ventricles is proportional to initial length of the ventricular muscle fiber, means when the muscles is not contracted. Increase in venous return means amount of blood returning to the heart increases the end diastolic volume, and that increases the length of the ventricular muscle fiber, which brings about increase in contraction and then increase blood ejection, means increase stroke volume. This is a figure showing a ventricular function curve which expresses the relationship between end diastolic ventricular volume in ml and then stroke volume in ml. The horizontal axis could have been labeled as sarcomeral length and vertical axis as contractile force. So whenever there is an increase in venous return from normal resting value, there is an increase in end diastolic volume, and thereby that also increases the stroke volume. So increase in venous return increases end diastolic volume, which increases the force of contraction. This is the Frank-Starling law. But this law is only up to the physiological limit, and that physiological limit is for the sarcomeral length from 1.8 micrometer to 2.2 micrometer. This physiological limit is also known as optimal length. So whenever there is an increase in end diastolic volume, the length increases up to the optimal length, as well as there is a continuous increase in stroke volume till the optimal length. But once the end diastolic volume is more and the length of the ventricle is beyond the optimal length, then there is a decrease in force of contraction. So again, within the physiological limit, the force of contraction is directly proportional to the ventricular length before its contraction, and this length is determined by the end diastolic volume, which is again determined by the venous return. Now let us talk about venous return. Return refers to the volume of blood per minute entering each atrium from the veins, and venous return is mainly dependent on the pressure gradient. So left heart, that is left ventricle, is under the high pressure, while right atrium pressure is almost 0 millimeter of mercury. So this high pressure gradient is the one that is responsible for the increase in venous return. The magnitude of flow through a vessel is directly proportional to the vessel pressure gradient. Much driving pressure imparted to blood by cardiac contraction has been lost by the time blood reaches the venous system because of frictional losses along the way, especially passes through a high resistance vessel known as arterioles. By the time blood reaches the venous system, the pressure averages to 17 mmHg. However, because atrial pressure is nearly 0 mmHg, a small but adequate driving pressure exists to promote the blood flow through the veins. So this promotes the venous return. Other factors that enhance the venous returns are sympathetically induced venous vasoconstriction, skeletal muscle pump, venous valves, respiratory pump, and cardiac suction. Sympathetically induced vasoconstriction. Venous smooth muscles is abundantly supplied with sympathetic nerve fiber. Sympathetic stimulation of venous vasoconstriction, which modestly elevates the venous pressure, in turn increases the pressure gradient to drive more of the stored blood from veins to the right atrium, thereby enhancing the venous return. Next is skeletal muscle pump. Many large veins in extremities lie between skeletal muscle. So muscle contraction compresses the veins. This external venous compression decreases the venous capacity and increases the venous pressure, squeezing the blood forward to the heart. This is also known as skeletal muscle pump. It promotes the venous return. This skeletal muscle pump also counters the effect of gravity on venous system. Veins are equipped with one-way valves. This is a fluid-filled tube, so whenever there is a point of constriction to certain area, then the fluid can move in the up and down direction. But in case of the veins, since it is equipped with one-way valves, whenever there is a contraction of skeletal muscles, there is a closed venous valve that prevents the backward flow of blood, and on the above side there is an open venous valve that permits the flow of blood towards the heart. So blood can only be driven forward because the large veins are equipped with one-way valves spaced at 2 to 4 centimeter intervals. These valves let the blood move forward to the heart but keep it from moving back towards the tissue. So this is the advantage of one-way valves. Another is respiratory pump. As a result of respiratory activity, the pressure within the chest veins is subjected to 5 mmHg less than atmospheric pressure, while the vessels in the abdomen and lower extremities, they are within atmospheric pressure. So there exists a pressure gradient between the lower veins and then chest veins, which drives the movement of blood flow towards the right atrium. So this is known as respiratory pumps because it is as a result of respiratory activity, and it occurs prominently during the deep inspiration. So increase in respiratory activity, skeletal muscle pump, and venous vasoconstriction due to sympathetic stimulation all enhances venous return during physical exercise. The last factor that promotes the venous return is the heart itself. Heart functions as a suction pump to facilitate the cardiac filling. During cardiac cycle, whenever there is a ventricular contraction, the atrioventricular valve is pulled. These valves are pulled downwards so that there is an increase in arterial cavity size. With this, there is a drop in arterial pressure transiently below 0 mmHg, so that there is an increase in veins to atrial pressure gradient and thereby enhance venous return. In the next, during ventricular relaxation, rapid expansion of the ventricular chamber during ventricular relaxation creates negative pressure in the ventricles, and negative ventricular pressure increases veins to atria to ventricular pressure gradient that further enhance venous return. So both are the cardiac factors during the cardiac cycle, and they are known as suction pump that promotes the venous return. So this is a summary showing the factors that facilitates the venous return. So for the increase in venous return, it is the main factor is the increased pressure gradient, which is imparted to the blood by cardiac contraction. Another is sympathetic venous vasoconstriction activity. Another is skeletal muscle pump activity, which are equipped with one-way valve. Another is respiratory pump that occurs during the deep inspiration, and another is cardiac suction effect during a cardiac cycle. While the last factor that also affects the venous return is the increase in blood volume, which is due to the salt and water retention and passive bulk flow of fluid from interstitial fluid into the plasma. So with the increase in blood volume, there is an increase in venous return, increase in end diastolic volume, and increase in length of the ventricle, and then increase in the force of contraction, thereby enhancing the stroke volume. So with this we come to an end. We have talked about the preload, one of the determinant factor for the stroke volume. The other two is myocardial contractility, and then afterload. That will be discussed on next video. Thank you.